Great, thank you very much, Morten. Actually, Alison Hall is the last panelist that you didn't introduce, but it's a great pleasure to step in for Dr. Cox regarding the top 5 interventional trials of the past year. And if you're going to ask how we decide about that, it's all discretionary. It's a black box, whatever I thought was best. But actually, there is some order to the chaos. So this is how PCI works. That's from step by step, putting together now a summary of what are the steps. And the trials we will talk about have to do with access, pharmacology, and then to some extent with imaging. So as you can tell, there are many other things we don't talk about, but some of those will be covered in upcoming trials down the line. So number 1, and that's a topic I love, it's about femoral versus radial. You may have seen at ACC the Safari STEMI trial. This was a study, was supposed to be close to 5,000 patients with ST elevation myocardial infarction, randomized to radial or femoral access. The primary outcome was all-cause mortality, and there were several secondary outcomes at 30 days. The expectation was that 4% would be the mortality in the femoral access, and that radial would have lower mortality. It was supposed to go to 5,000, but actually the study was stopped early by the DSMB after they randomized a little over 2,000 patients. And this is a study that's contemporary. A lot of the previous radial trials in STEMI were done with very high rates of P2Y12 inhibitors, not the best femoral technique. In this case, it was done with unfractionated heparin in most patients before, but about 88% got bivalirudin in the actual trial. And glycoprotein 2B3 inhibitors were only used in 6% of cases. If you look at the crossover rates from femoral to radial, they were 8%, so not a huge number, but it did happen. And importantly, almost 70% of patients in the femoral axis did have a femoral closure device. If you look at the efficiency, there was about 2-minute delay in terms of arrival to the cath lab and getting the first balloon up. And there was about 1.2 minutes, a little more fluoroscopy time and radiation dose in the radial access group. The surprise came that the mortality was actually the same. 1.5% in the radial, 1.3% in the femoral, in the radial, completely contradicting several of the prior trials. If you look at secondary outcomes, no difference in infarction, stroke, or the composite endpoint. And even more surprising, there was actually no significant difference in bleeding, whether you define it as non-Cabot STEMI major or NDMI major, no difference in transfusion. So completely different than everything else we've seen in the previous trials. So even though if you put it in the meta-analysis, you still radial comes ahead, but the lessons are completely different than what you've seen before. And I think that gives hope to the femoralist in the audience and overall, that femoral done properly and done with good technique by not using a lot of 2B3 inhibitors, using closure devices, may actually be good. And I think there's a new hashtag for Twitter, make femoral great again. So we'll see if that's what's going to happen. But a lot of action in that group. Going to the second trial, Augustus, that was presented at ESC. This is a large trial of apixaban versus vitamin K inhibitors. And this is the largest trial of novel direct inhibitors, but also it was done in a way that you can separate the effect of the DOAC versus the warfarin, and also separate the effect of aspirin versus placebo. So the first randomization was to apixaban versus factor V K inhibitor, and secondary randomization to aspirin versus placebo. The baseline characteristics of the patients were typical, about age of 70, 29% were women, and the mean SADS-2 VAS score was about 4. The Has-Bled score is about 2.9. So if you look at the event rates, in terms of bleeding, when you compare apixaban with vitamin K antagonist, it was significantly less, as you might expect, about 4% absolute risk reduction. If you look at aspirin versus placebo, even more dramatic difference, 16.1% versus 9%. So clearly aspirin, major contributor to bleeding. If you look at the efficacy in terms of death and hospitalization, significantly decreased in the apixaban group, 27.4 versus 23.5. And then if you look at death hospitalization with aspirin, no significant difference, although the bleeding was significantly higher. So the conclusion of the study was that in patients in AFib who require anticoagulation, the best group was actually apixaban with a P2Y12 inhibitor without aspirin, which is in agreement with the previous studies. But what's different here is that the dose used is actually the dose that is indicated for AFib preventing stroke. In the previous study, there was actually a little lower doses of vitamin K and direct oral anticoagulant inhibitor use. Going on to number 3, this has to do with ticagrelor monotherapy. And this is relevant because in TCT, the Twilight trial is going to be, and this builds on the concept that having a single antiplatelet therapy and taking away aspirin, which you saw in the previous study, that it has a lot of bleeding when you put it on top of direct anticoagulants, can we make things safer and decrease the bleeding without a penalty in terms of the ischemic events? That was a fairly complicated design. The reference strategy was what's standard right now, which is ticagrelor for a year and then continue aspirin up to 2 years, or clopidogrel for stable CAD patients, so ACS ticagrelor, stable gut clopidogrel. And in the experimental, everyone, ACS or stable CAD, received aspirin essentially for the first month, and then went on for ticagrelor 90 milligrams BID for 2 years. So very, very large trial. And there was actually no significant difference between the two groups in terms of all-cause mortality and also in terms of bleeding. So a little surprising outcomes. People might have expected that you might have less bleeding and less ischemic events, less mortality, but actually this did not pan out in this group. So the current approach of giving a P2Y12 inhibitor for 12 months followed by a low-dose aspirin remains the standard of care for now. Going on to number 4, the ultimate trial, switching over to imaging, that was presented at TCT last year and published in JACC. And this is an all-comer study that randomized patients undergoing PCI to IVUS guidance versus angiography alone, primary endpoint TVF at 12 months. And it did use some fairly aggressive criteria for optimal stent deployment. The MLA was supposed to be more than 5 millimeters square or more than 90% of the distal reference lumen cross-sectional area. You're not supposed to have geographic miss, so you shouldn't have plaque burden more than 50% in the 5 millimeters proximal or distal to the stent, and you shouldn't have a dissection that is more than 3 millimeters in length. A lot of screening. Eventually, there were about 1,400 patients randomized 1-to-1. And the difference in the procedure was that the stent length was slightly longer, but you had larger diameter, larger balloon diameter, and a little higher post-dilation pressure. So what you do different is you may put a little longer stent, you may go a little higher on your balloon, and also higher pressure on the balloon post-dilation. And what was found at 12 months is that TVF was significantly less, almost half, in the group that had the IVUS guidance compared to the group that did not. There was also a trend for less stent thrombosis in the IVUS guidance group. And this is the Kaplan-Meier curve. You see there's actually immediate separation of the curves, but the separation actually increases as time goes by. And then the composite endpoint of definite stent thrombosis of TLR was also less in the IVUS guidance group. Now, if you take the patients who actually had optimal guidance, the ones that actually fulfill the criteria, the 3 criteria mentioned before, there was even more pronounced difference, 4.4 versus 1.6% in 12-month target vessel failure. So there are some limitations in the study, and the follow-up is relatively short, but it still shows fairly conclusively that intravascular imaging is improving the outcomes of drug-eluting stent implantation. And then the last study, that's a little less known study, actually it's not published, but I find it provocative because it's something we don't routinely do. And this was the first kind of large systematic prospective study looking at coronary physiology in patients undergoing PCI. This used IFR before and after the procedure. Of course, to be in the study, you had to have an IFR of less than or equal to 0.89. And then the typical characteristics of patients with high frequency of diabetes, previous PCI, myocardial infarction. And this was a single-arm study. So all patients underwent physiology before and after, but the after measurements were actually blinded. So the operator did not know about what was happening after the procedure. And what was found is that in about a quarter of patients, the post-PCI IFR was still ischemic. And then if you look at the pullback and did you see a specific step up, or was it a diffuse increase in the pressure, about 80%, so 4 out of 5 lesions had actually a discrete step up. Now, if you look more specifically, where was that gradient? In about a third of the patients, it was within the stent. And then about a third, it was actually on the proximal part, and in about a third was also on the distal part. So what this implies is that potentially, if we take more attention in our stent placement, fits perfectly with the IVO study that we presented before, you can potentially improve some of the cases. In the diffuse increase of the IFR, you cannot, but in the ones with discrete steps, maybe doing a better job with stent deployment or putting additional stenting, maybe in the proximal or distal edge, might improve the outcomes down the line. Couple of thoughts about the anticipated studies, and I think these were discussed yesterday by Dr. Dengas. There's a lot of exciting things coming up. In the European Society, the COMPLETE study is going to be coming, which is a study of complete versus cardiopulmonary revascularization in ACS. And then ECLIPSE, we don't know yet where it's going to be coming, but ischemia will be presented most likely at the American Heart in November. And then TWILIGHT will be presented at TCT. And there's, of course, FAME3, which is still enrolling. So a lot of exciting things coming up in terms of products. You have the Shockwave going through trials, and there's some new CTO wires that are exciting to get in the upcoming year. So before finishing, a couple words about 2 of the SCAI meetings. SCAI Shock is coming up in September 6 to 8 in Boston. Second meeting, it was very well attended last year, and really a deep dive on how to optimize outcome in shock patients. And finally, let's not forget the major meeting, SCAI 2020. Actually, Dr. Kern will be moderating for the first time in the main meeting, interventional jeopardy. So just for this alone, you should come and be at the meeting. So again, thank you so much, and thank you for coming.